The topic of today's session is medical care of the post-liver transplant patient from a primary care perspective. I have no financial disclosures related to the topic of this lecture. In order to begin to understand how to care for patients with a liver transplant, it is important to understand the operation. In the United States, the standard liver transplant is performed in an orthotopic fashion. This means that the donor liver is placed in the same position as the recipient's diseased liver. Therefore, the surgery begins with removal of the recipient's liver, and in its place, the new liver is sewn into place. Generally, there are 3 areas that need to be attached, and this includes the biliary system, the venous system, and the arterial system. Generally, the duct is connected via a duct-to-duct anastomosis, and occasionally in this type, a T-tube may be placed to stent the anastomosis. This was done more often previously, but now many transplant centers have abandoned this and leave the anastomosis without an external stent. Occasionally, the duct is connected via Roux-en-Y anastomosis, where the donor duct is connected to the recipient jejunum. This is often performed in patients who have primary sclerosing cholangitis, as the recipient duct is diseased. Overall, there has been tremendous success in liver transplantation, with survivals approaching 90% in 1 year and around 80% in 5 years. Long-term survival of over 10 to 20 years is very common and expected. As a result, patients are living quite long, and generally after the first year, it is the medical problems which predominate, highlighting the important role for primary care providers. The types of complications that present after liver transplantation is very much related to the timing. Allograft-related complications such as rejection, biliary complications, and vascular complications occur early on, usually within the first year after liver transplantation. Recurrent disease, such as recurrent hepatitis C, also occur reasonably early. Non-allograft-related complications, such as medical complications occurring as a result of immunosuppressive medications, can also present early, but usually predominate later in the patient's course. One of the most appreciated complications after liver transplantation is rejection. Rejection can occur in the form of acute cellular rejection or chronic ductopenic rejection. Acute cellular rejection most commonly occur within days and weeks after liver transplantation. Unlike other organs such as heart or the kidney, the liver is relatively immune tolerant. Rejection can occur, but it is usually a rare cause for graft loss. It is also very unusual for acute rejection to occur after the first year. If this occurs, one has to suspect that the patient has compliance issues with their immunosuppressive medications, or that the metabolism of their immunosuppressive medications may have been altered because someone inadvertently prescribed a medication which interfered with either the metabolism or the absorption of the immunosuppressives. Acute cellular rejection often presents asymptomatically with just elevations in the liver enzymes. This is why patients are asked to routinely be monitored with blood work every 2 to 3 months. It is because the patient would otherwise not know if they were rejecting. As a primary care provider, it is important for you to know the patient needs frequent monitoring of their labs. This usually includes CBC, a basic panel, LFTs, as well as their trough calcineurin inhibitors, tacrolimus, or cyclosporin. The pattern of increase in liver enzymes that occur in rejection is very nonspecific. The characterization of whether something is cholestatic or hepatitic is unfortunately not very useful post-liver transplant, as both acute rejection and biliary strictures can present with any pattern of liver's enzyme elevation. The diagnosis of rejection requires a liver biopsy, which has characteristic findings. Treatment starts with IV steroid pulses, which usually solves the problem, but occasionally refractory cases occur requiring treatment with OKT3 or thyroglobulin administration. Chronic rejection is a form of rejection which is characterized by the gradual loss of small bile ducts, ductopenia, and microvascular changes. It is often manifested by cholestasis with an increase in alkaline phosphatase and bilirubin. It occurs in less than 5% of liver transplants but can be devastating. Chronic rejection may respond to an escalation in immunosuppression or change to tacrolimus if the patient is on cyclosporin with and without the addition of mycophenolate. Some patients do fine with chronic rejection, and other than persistent abnormal liver enzymes, do not require any further treatment. However, others have required retransplantation. The diagnosis of chronic rejection requires a liver biopsy, which shows ductopenia with a relative paucity of immune cells. Other than rejection, biliary complications represent a major cause of morbidity and mortality after liver transplantation. Often referred as the Achilles heel of liver transplantation, it is actually relatively common. The incidence is estimated to occur in 10 to 25% of liver transplant. The cause for biliary complications are multifactorial, including technical issues with the anastomosis, vascular insufficiency, and other causes. The different types of biliary complications include bile leak and both intra- and extrahepatic strictures. Vascular complications are relatively uncommon. Hepatic artery thrombosis can have variable presentation depending on when the thrombosis occurs. If it occurs early after liver transplant, the patient can actually present with fulminant hepatic failure. But later on in onset, this can result in biliary necrosis and hepatic abscess. If it presents late, hepatic artery thrombosis can actually present as chronic biliary strictures. Portal vein thrombosis is rare and can present as elevated LFTs or at times hepatic encephalopathy. Venal caval obstruction is also unusual but can present early as massive lower extremity edema. Although these allograft complications can result in about 42% of the reasons for mortality in liver transplantation, they are generally the ones that can occur under the care of either the transplant center or your transplant hepatologist. What is more important perhaps for the primary care provider is to realize that 58%, the majority, of the reasons for late-term mortality in liver transplant recipients is actually not hepatically related. Rather, a large proportion is related to malignancy and cardiovascular disease. Diseases where a primary care provider can have a lot of impact. In approaching the type of problems that may affect your patient with the liver transplant, you should have an understanding of the immunosuppressives that are used, as they are generally one of the reasons for morbidity and mortality long-term. Generally, most liver transplant centers will start with a regimen of 3 types of immunosuppressives after transplantation. However, unlike other organs such as kidney transplants, liver transplant recipients are generally only on one medication after 1 year of transplantation. This is usually the calcineurin inhibitor, cyclosporin, or tacrolimus. If your patient is on the other medications, mycophenolate or steroids, it should only be because they have problems with rejection, recurrent, or de novo autoimmune hepatitis. Despite the critical importance of the 2 calcineurin inhibitors, cyclosporin and tacrolimus, in allowing for transplantation to be successful, these 2 medications have significant side effects. They can cause significant morbidity and mortality post-transplant. We often warn our patients that they are trading one disease for another set of disease. Common side effects for cyclosporin include hypertension, renal dysfunction, and less common but can still occur as hirsutism, gingival hyperplasia, hypomagnesemia. Similarly, tacrolimus causes post-liver transplant diabetes, headache, which are often dose-dependent, hyperkalemia, renal failure, tremors, hypertension, and hypomagnesemia. Azathioprine and mycophenolate may also have side effects, including mostly bone marrow suppression and GI side effects. These side effects are generally not as prominent as those caused by the calcineurin inhibitors. Steroids can also have significant side effects, which are likely well known to you. It is important again to reiterate that most patients are withdrawn from steroids early after transplant and usually by 1 year. In regards to what you need to know about immunosuppressives, one of the most important aspects is check for interactions with calcineurin inhibitors, because medications which affect the cytochrome P450 activity can be devastating to someone on calcineurin inhibitors. For example, if you were to prescribe to your patient a macrolide, such as clarithromycin, it may decrease cyclosporin 450 activity and increase drug levels, leading to your patient developing renal failure due to toxic levels of their calcineurin inhibitor. Similarly, other drugs like St. John's wort can actually decrease levels and precipitate rejection. Therefore, it is important to check for drug-to-drug interactions, particularly with calcineurin inhibitors, before prescribing a medication to a post-liver transplant patient. Other common post-transplant medical problems include renal insufficiency, hypertension, diabetes, dyslipidemia, obesity, cardiovascular events, osteoporosis, malignancy, and gout. With regard to renal insufficiency, this is very common and likely related to the calcineurin inhibitor. By 5 years after transplantation, 22% of patients have renal failure. It is very important to recognize that because of the calcineurin inhibitors, your patients are very prone to renal failure, and thus nonsteroidals and other nephrotoxic drugs should be avoided. It is very important for the primary care provider to address your patient's cardiovascular risk after transplantation. These include hypertension, diabetes, dyslipidemia, and obesity. All are commonly related to the immunosuppressive regimen. The 1 and 3 year overall cumulative risk of a cardiovascular event are 4.5 and 10.1% respectively in patients after liver transplantation. In comparison with all other etiologies, patients who are undergoing liver transplant for non-alcoholic steatohepatitis have a significantly higher risk of cardiovascular events the first and third years after liver transplantation. Bone disease is also very common and highest 6 months after transplantation. A high degree of vigilance for osteopenia and osteoporosis is required. De novo malignancies is also a problem, presumably due to the immunosuppression. There is particularly an increased incidence of skin cancer. Hyperuricemia is also very common after transplantation, although gout is less common. The causes are multifactorial, including the calcineurin inhibitors and renal insufficiency. The combination of allopurinol and azathioprine can lead to life-threatening myelosuppression, so for the few patients who are still on azathioprine, this is important to not prescribe allopurinol or change the azathioprine to something else. Non-steroidal use is also risky for acute attacks, but colchicine can be used. In conclusion, liver transplantation represents a life-saving procedure for patients with end-stage liver disease, but it is fraught with multiple medical problems requiring long-term care by their primary care providers. Avoidance of prescribing medications which interfere with calcineurin inhibitors and nephrotoxic medications is important. Priority should be placed in addressing cardiovascular risk factors.